we are going to get this program started because Dr. Boster does have things to do. And if you don't know Dr. Boster, you wouldn't be online. So I guess you already do know him, and you see the conversation that he's going to be speaking about tonight. He will be speaking for about 30 minutes, and then we'll open up the floor to Q&A, all right? This program tonight is sponsored by Sanofi. And Dr. Boster, take it away, and I'll be back on when you're ready.
Aaron Boster here, and as always, thank you for learning about MS with me. Thank you to MS Views and News for creating this opportunity to speak with you guys tonight, and thank you to each and every one of you who have taken some time out of your evening to jump online for this kind of fireside chat. My name is Aaron Boster. I'm the head of the Boster Center for Multiple Sclerosis, which is a single-point healthcare company where we care for families impacted by MS, literally from around the globe. Stuart and I have been partnering up, bringing you new updates, and today I have quite an exciting new update to share with all of you. So today we're going to be talking about the MS diagnostic criteria, which were recently codified and updated. So there was a 2024 update to the diagnostic criteria. So for an MS nerd like myself, this is a really, really big deal. And I thought it would be great to be able to talk to you guys about it tonight. For starters, let's talk about what is a diagnostic criteria anyways? What does that even mean? Certain diseases, we've developed tests to prove that someone has it. So for example, if someone is being worked up for diabetes, I can draw one laboratory, and if that laboratory is positive, I can say, ha, they have diabetes. There's other conditions where I can prove they have a condition with just a simple test. So that's called a diagnostic test to confirm that someone has an illness. Not all illnesses, not all diseases have a diagnostic test like that. And in MS, we don't have a single blood test that you can send off to prove that you have MS. Instead, we have a set of rules and guidelines where certain characteristics of the patient with certain exam findings and certain other things line up, then we can confirm a diagnosis. And there are many conditions out there where we don't have a single test, but we use a set of criterion to help confirm a diagnosis. And that's what we're talking about, is the way that we confirm that someone has multiple sclerosis. Now, who cares? Why is this relevant? So what that there's an updated criteria? The reason it matters is because with each evolution of the diagnostic criteria, we get faster at making the diagnosis, and we do it more accurately. And that's really, really important. So the faster we can diagnose someone and the more accurate we can diagnose someone, the faster we can get them on appropriate therapy. And one of the things that we've learned over the last decade in MS is that the faster you diagnose and the faster you start on therapy, the better the person does long term. So this actually is really, really meaningful to me in my clinical practice as I take care of my patients. Now, the way that I would like to frame the updates is I would like to frame it the way that I think about diagnosing a patient in clinic. There's 5 elements to an MS diagnosis if we use patient-friendly language, which I would like to do. Number 1 is your story. Now, we call that the medical history or the clinical history because that sounds highfalutin, but it's literally like the stuff you tell me. Number 2 is your neurological examination. So when we're running you through the MS Olympics and torturing you, that's the second piece, the neuro exam. Number 3 is the pictures, the MRIs. What do they look like? Number 4 is spinal fluid if it's obtained. And number 5 is, hey, prove it's nothing else. So these are the 5 elements that we go through when we're trying to clarify an MS diagnosis. And I'm going to go through each one of them, highlighting the changes to the diagnostic criteria. So let's get started. When you think about the clinical history, what are we listening for when we're abstracting clinical history? We're really listening for one of 2 things. We're either listening for a classic presentation of an MS attack, where something bad happened to you and it got worse and then it stayed bad for a bit and then it got better. And that thing that was bad was a neurological thing, which is commonly seen in MS. We're listening for that attack. Or we're listening for a year of slow progression. Those are the 2 things that we're listening for. And that hasn't changed. So we're still listening for that. But we've gotten more honest with ourselves and smarter, because now we recognize that sometimes patients do not present with classic attacks. So a classic attack would be like an optic neuritis or a transverse myelitis or a brainstem syndrome. Those are very classic presentations. But we now, in the new diagnostic criteria 2024, recognize that sometimes people don't present like that. Like, you're not a textbook, and someone might have a seizure and then go on to get an MRI that looks like MS. And that now also counts as a consideration for possible MS. That even an asymptomatic, or excuse me, an atypical presentation may count towards the diagnosis. It gets even more intense because also, as it relates to the story, sometimes people have no story. There's no clinical history. They have absolutely no neurological history whatsoever. Nothing's happened to them. They got an MRI for some other reason, and oh my goodness, it looks like MS. But they haven't had any clinical symptoms. Previously, we said that's impossible, can't be MS. Now it can. We call that radiologically isolated syndrome, where you have no clinical history, but if other things fit the picture, then we can actually make a diagnosis that early. The other thing we've done, updating the clinical history, is we recognize that people who present with possible MS under the age of 18 are different than 18 to 50, and that people that present with possible MS over the age of 50 are in some ways different than 18 to 50. And so with those different age groups, we now have different considerations to the criteria. Lastly, as it relates to history, well, no, I'll stop there. So those are the updates to the first one, to the medical history. And all of those updates are honest and genuine. They make perfect sense to me. And what they allow us to do is to get at a diagnosis faster. We no longer are hand-tied that if you didn't have a classic attack, then it can't be MS. In fact, when I was in training, I asked my mentor, why can't a seizure be an attack? And he said, because it's not, which is not a very good answer. All right, number 2 is the neurological examination. So what are we doing on the neuro exam when we're making you follow the finger and do all the different things? We're looking at the various parts of your brain and spinal cord, the functions, and we're seeing if we can find evidence of problems which match your story. So in other words, if you say, Dr. Boster, sometimes when I walk, I'm unsteady on my feet and I can like bump into a wall. Then when I'm walking with you in the hallway, I'm looking to see if you have any difficulties with your gait. So I'm trying to match up your neuro exam to your history, okay? And that hasn't changed very much at all. We still use the neuro exam as one of the primary tools to look for evidence of neurological disability. Now, I'm going to make a sidebar that I think if you look at the history of the criteria, we're actually going to start to value the neurological exam less and less and less, because the other tools, MRI and other things I'll talk about in a second, are so much better, so much more sensitive, that I think that probably within my lifetime, we won't even use the neuro exam, but that's conjecture. All right, so number 1 is your story. Number 2 is your neuro exam. Number 3 is imaging. And there's been a lot of updates to the MRI. Back in the ancient days of yesteryear, circa 1970s into the early 80s, the MRI didn't exist. And so the way that we would have to diagnose is you have an attack and then you wait around for a second attack, which could happen years later. Then when the MRI came out, it was, ooh, you can have your first attack, and then if we see changes on the MRI, we can diagnose sooner. And so we added the MRI officially in 2001 with the McDonald criteria. And each rendition of the updates, we had an update in 2005, an update in 2010, an update in 2017. We were learning how to use the MRI better and better and faster and faster and faster. In 2024, the new criteria, again, we've updated the way that we use the MRI so that we can do things quicker. The first MRI update is we're now able to call more parts of the brain to count towards an MS diagnosis. So you've heard about looking for spots in different locations, and we look for spots just so you hear the words in the periventricular white matter, in the juxtacortical position, cortex, the brainstem, and the spinal cord, and those haven't changed. But now a spot in the optic nerve also counts, which is really, really useful because 25% of people that present with MS present with optic neuritis. And the old criteria didn't allow the optic nerve to count. Now it does. So that's a really big deal. And you can diagnose optic nerve dysfunction, not just with an MRI, but you can use other techniques too. You can use a machine called the OCT, or you can use a test called VEP. Those are different kinds of eye tests. And that is really, really valuable. And so this means that when you are working someone up for MS, we're going to get the brain MRI the way we have been. We're probably also going to get orbital MRIs, and we may be sending them to ophthalmology to get those 2 special eye tests. So that's one of the updates to the MRI. A second update to the MRI is bringing into bear new, evolved, really, really exciting advanced technologies, MRI technologies, which teach us specific things about MS. Let me say that more succinctly. When you get an MRI and you see a white spot, there's lots of conditions that cause white spots. So that could be an MS spot, or it could be a bunch of other things. And we now have new MRI techniques that clarify that's absolutely an MS spot. So let me talk about that. And in order to explain it, I need you to envision an MS white spot. Okay, so you're looking at an MRI and there's a white spot on the screen. What has happened is the autoreactive, the naughty cells, which are in the bloodstream, they leave the bloodstream and they enter the brain through the blood vessel. And then when they leave the blood vessel, they kind of spread out like in a growing circle, and that's the spot. So it stands to reason that if you had a really good MRI, you might see the blood vessel in the center of the lesion. And that is exactly what this new MRI technique can do. And it's called the central vein sign, because you can see a vein in the center of the lesion. Why is that exciting? Because most other conditions don't do that. So now, if you're looking at an MRI and you see a white spot and there's a dot in the center on the special sequence, a central vein sign, that's more likely to be demyelinating. And if you see 6 of those with those spots, that's very, very likely to be MS. If you have, say, 4 spots and half of them or more show the central vein sign, that's very, very likely to be MS. And that's a really big deal, because for decades, when we look at a white spot, we're kind of guessing based on the size and the shape and the location. Now we can use an advanced technique to see if there's a central vein sign. And that's a new addition to the MRI. There's a second new addition to the MRI. Let's go back to that spot that I was talking about, where the naughty cells from the immune system enter into the brain through the blood vessel, and then they grow. On the edge of the lesion, on the rim of the lesion, you have cells, immune cells, that are unfortunately eating the tissue. And as a result, they lay down iron. All right, and there's a reason for that, but let's excuse the details. So you can get a rim of iron around the lesion. Now, about less than 20% of people with MS may actually have that change on any given MRI. But if you see it, it's almost guaranteed to be MS. So my point here is, as we evolve our diagnostic criteria, now we have an MRI with new tools which are more specific for MS, which is very, very exciting. So when we think about your story, your exam, your MRIs have been really updated a lot. The fourth thing is spinal fluid. And spinal fluid is really valuable and is now a very important part of MS diagnosis. Let me explain. MS is an autoimmune condition where your immune system is overly active, except it's only overly active in the central compartment, brain and spinal cord. It's not overly active in the bloodstream or in your arm or something like this. So one of the ways that we try to clarify that the problem you're having is because of an overly active immune response in the central compartment is by sampling the immune system in the central compartment. We draw spinal fluid from the central compartment, and we draw blood. Normally, in a normal person situation, they have a lot of antibodies in the blood and not very many in the spinal fluid. But in someone with MS who has an overly active immune system in the central compartment, they have way more antibodies in the spinal fluid and not as many in the bloodstream. And that's what we're looking for when we do spinal fluid. Now, what do we actually look at? We look at something called oligoclonal bands, or OCBs, or bands. And those are really measuring the antibodies. Well, now with the updated criteria, we have a second test, which is also very, very sensitive and is also looking at antibodies slightly differently, called kappa light chain. So sometimes the kappa light chain will be positive when the bands are negative, and the bands can be positive when the kappa light chain is negative. So by having both, we increase the sensitivity of the spinal fluid, and that's a big deal. Now, the fifth thing that we talk about in diagnostic criteria is prove it's nothing else. And the new diagnostic criteria do a really good job of this. Let me explain. We recognize that children can have MS. I've diagnosed a 6-year-old, I have diagnosed a 7-year-old with multiple sclerosis before. But there are other conditions that children are more likely to have. And in the criteria, they want to make sure that you don't misdiagnose a child. So we've added a special call out that if you're under 18, we should send off a blood test called a MOG to look for a mimic of MS, particularly in children. And that helps ensure that we're not misdiagnosing someone with a cousin of MS with MS if they're under 18. So that's really great. On the other end of the spectrum, when you deal with someone who's over the age of 50, and that's not old, not at all, but we draw a line in the sand at 50. If you're diagnosing someone and they're over the age of 50, we recognize that someone 50 and older has an increased risk of having spots just because of age or vascular things like from having high blood pressure or migraines or something. So we want to make sure that we're not misdiagnosing someone who is in their 50s or older because they may have some of those other things going on. And the average age of onset of MS is 30. So if you're dealing with someone in that age, the new criteria suggests some extra added tests. You want to make sure that that person has either positive spinal fluid or they have central vein sign positivity. And by ensuring that, you're kind of making sure that we don't over or misdiagnose someone who's over 50. And I think that's a really big deal. Now, there's a couple other things about the diagnostic criteria which have been updated, which I think are really, really impactful. Number one, they've done away with this concept of dissemination in time, where you have to have events in different times because it turns out that it's not necessary for the criteria. So dropping that is kind of a big to-do because for as long as I've been in practice, that's always been an element where you have to prove dissemination in time. Now you don't have to in the way that I just explained. A second thing that I think is really, really, really important is that we've now identified that the criteria for primary progressive MS and relapsing MS are the same criteria. And to me, that speaks volumes because in my heart, I truly believe that there's actually only one disease. MS is actually one condition, and it can present and look differently. So just to make sense of that, like I'm a human man and I am really short. Now, I have some friends that are human men and they're really, really tall. Like, so I'm like 5'5.5", and my friend's 6'9". And when we stand together, it looks like we're different animals because I'm like this teeny tiny guy and he's this like huge giant guy. But the reality is we're both adult men, but we phenotypically look different. I think in my core that primary progressive MS and relapsing MS are the same disease that present differently. And the fact that these diagnostic criteria identify one unified criteria, I think speaks to the fact that we're really dealing with the same disease. And that is very, very important to me. All right, so as we wrap up, let's try to address why is this relevant to you, right? So if you have multiple sclerosis, how is this relevant to you? Well, it's not going to change the diagnosis. If someone's already diagnosed, we don't have to reapply these new diagnostic criteria. And if you meet the diagnostic criteria before, we're not going back and revisiting that. So that doesn't apply to you. But here's something that I do think that you should think of if you are in the MS community because you have MS. The people taking care of you, the global treating MS community, we care a whole lot. And I am really proud that we've just updated the criteria so that we can do a faster and more accurate job of diagnosing people with MS. That's a really big deal. Secondly, something else that I think is really important. Traditionally, MS doctors were rich, white, Christian men. That's true. And that's not very diverse. And I'm really proud that when you look at the group of neurologists that updated the criteria, they were of different genders and they were of different ethnicities. And I'm proud of that, gosh darn it, that our field is evolving. And not only are we trying to be more inclusive for patients involved in clinical trials, we're trying to be more inclusive even amongst ourselves as we develop criteria. So yay. Now, what's the take home or what's the value if you're being worked up for MS? This is very, very relevant. Here's the things that we need to take away. Number one, we need to be sensitive to the fact that you don't have to have a classic story to be worked up for MS, right? And so that's a change that I'm very proud of. Number two, if you're having an MRI, you want to make darn sure that the MRI includes the orbits, not just the brain. It includes the spinal cord, not just the brain. And you want to make sure that it has those new sequences, a central vein sign sequence, that's not what it's called, but that'll get you there, and a PEARL, paramagnetic rim sequence. Or you can just say to the neurologist, make sure my MRI has a central vein sign and PEARL, right? You want to make sure that those things are there. If you're having a spinal tap, make sure the neurologist is sending both oligoclonal bands and the kappa light chains. And if you are over 50 or if you have vascular risk factors like diabetes, remember there's extra steps to ensure that it's actually MS. And if you're under 18, remember there's a couple extra steps to make sure that we really are dealing with MS. So thank you for letting me take a few minutes out of your life to share something that I think is really, really exciting. The fact that we've now just updated the MS diagnostic criteria. I'll kick it back to Stuart and then we can start answering your questions.
So thank you very much, Dr. Boster. I'm hearing everybody applauding because that's what they do, right? So thank you very much for this conversation. And, you know, there are several people online that have asked questions, but there are many, many, many more online that have not asked questions. So if you have a question for this expert neurologist, I suggest you start typing away and let us get the question asked so you can have your answer completed. On what you were just talking about for what people should know with the orbits and the PEARL and the central vein sign, where can they read more about that? Do you have your own videos on that, you know, that they can refer to, or what?
So Stuart, this is the first time that I've presented this information ever. I will very likely make a YouTube video at some point on my channel as well, although you're hearing it here first. Momentum is a free newsletter made by one of the MS societies, so the National MS Society. And in the Momentum newsletter this month, there's a piece on the diagnostic criteria. So there's a lot of different locations where you can learn about it. I'll put something on my channel soon.
That's great. In fact, we put something on our blog the other day about the new criteria that's going on as well. So people can go there too. So questions though that have come up to me that people have asked, and then I'll get to some that are online. A person was recently visiting with their neurologist, and they find that their ever little symptoms over the years seem to accrue, and you know, pain gets worse. Sleeping at night gets worse because they have more pain during the night. Their legs either flop around for those that are having that issue, or for others that they're getting a tightness in their feet, or toes might be curling up, or their legs just stiffen totally out. What would you recommend for people that are having these different issues?
So it reminds me of a ball of twine, right? That you want to sort out or unravel. So you grab onto one, hook, and you start to pull on that loop, and then you find that there's a knot, and you pull another one, and you start to slowly unravel it, and then eventually it gets all unraveled. So you're sharing a situation where there's a constellation of symptoms, and they're all interplaying with one another. For example, if you have spasticity, which is making it so you can't sleep at night, then you don't get restorative sleep, which will make your spasticity worse. So that's just an example. And so what I think we need to do is we need to listen, and we need to start to pick apart what the worst symptoms are. And then we want to try to use symptomatic medicines to try to slowly knock away at that. And it's probably going to take a couple clinic visits to sort that out over time. So what would I do in preparation for that is I would write down the things that are really bothering you, so that you can bring that to the attention of your neurologist and say, please help me sort this out.
Right. And for those of you that don't know how to write, but you do have notes in your cell phone, you could type them into there as well. And then you'll have it right there, and you can't ever say, I left my note at home, because we know you're not going to leave your phone at home.
Yeah, or you can just dictate a note if you have to.
That's right. All right. First question online for Dr. Boster. It reads, if BTK inhibitors are approved, how long after Ocrevus infusions can I start a BTK?
So let's talk about that a little bit. So we've been talking about bruton tyrosine kinase inhibitors, or BTK inhibitors, now for several years, because we've been studying them actively in different forms of multiple sclerosis. And we've been talking about some of the evolution of these trials. Right now, one of the trials was found to be successful, the Hercules trial for a medicine called tolebrutinib, and it is in the hands of the FDA as we speak. So the FDA promises to weigh in by December. So they're going to give us an answer and say whether they're going to make this drug available or not. So the question being asked is, well, how soon do you start it after you stop another drug? And the answer is we don't know yet. We don't know what the label will say if it's approved, and that will give us some guidance. I can tell you what we did in the clinical trials was people had to be off the certain medicines for certain lengths of time. So for Ocrevus, they had to be off for at least 6 months, and the laboratories had to normalize. Now that was what we did in the trials for that particular study. What we do in clinical practice may be slightly different, and so the jury's still out. So hang on, we should learn more very soon.
So question going back about the tolebrutinib is, if this is, though, for non-relapsing secondary progressive, with the new ICD codes that are out there, which you did not discuss, but maybe one day you will, how will a person that only has secondary progressive and not non-relapsing secondary progressive be able to use this medication?
So that, Stuart, is the most contemporary question that could be asked today. So let's talk about that. So I just finished sharing with you that the global MS treating community, the doctors that take care of MS, have just updated the diagnostic criteria, and they've recognized that it's one disease, and they've merged the diagnostic criteria for progression and relapsing into one diagnostic criteria, which is the right direction to go in. Meanwhile, non-MS neurologists are doing the exact opposite. So our government, Medicare, just made something, a big change, not in the way that we work up MS, but in the way that we code the diagnosis for billing. So many people with MS have heard us say G35. So G35 for the last, I don't know, at least 2 decades, has been the diagnostic code for multiple sclerosis to bill. And that's dictated by Medicare, by our government. And they came up with an update, and they said they've ended G35. That doesn't exist. Now they have G35.A, G35.B, G35.C. And what they've done is they've tried to create different diagnostic codes for different flavors. So active relapsing MS, inactive relapsing MS, active secondary progressive MS, inactive secondary progressive MS, active PPMS, inactive PPMS. And frankly, it really, really upsets me because that's not biologic. That's the exact opposite of the direction we're needing to go in. And I'm very fearful that third-party payers like Medicare or other third-party payers like insurance companies will make things up. And they'll say, well, we're not going to approve your MS drug for G35.B, only for G35.A. And they'll try to slice things up in ways that disallow patients from having access to care. That's a major concern that I have presently.
As for many as well. All right, next question. Is there still a need for gadolinium?
I think there's still value in gadolinium. I think that a contrasted scan gives me more information than a non-contrasted scan. And if there's a concern, like let's say that you don't want it, then we don't do it. I still learn a lot of information. I just don't learn as much information. It's very rare that someone would have an enhancing lesion without a white spot, although I have seen it in my clinical practice. So I still get contrast in my patient scans as long as their kidneys are normal and they're comfortable with me doing it, because it teaches me a bit more information. Will there be a day in my practice when maybe we stop doing it? Maybe. I don't think anytime in the near future. I still think that it's very useful as it relates to a new diagnosis when you're working someone up for MS. I still very believe that it should be added to the initial workup with those initial scans.
So going forward with that, so you're saying that you would need to make sure that a person's kidney function is working well first. So therefore, then they would need blood work first, so you can make sure their creatinine levels are correct.
Yeah. Now, the good news is by the time you get to a neurologist, you've had some labs. So I don't think I've ever seen a patient that comes to me from a primary care without having a comprehensive metabolic profile. So it's very rare that we have to order brand new labs. We just need to look and make sure that their kidneys are okay.
Right. And isn't it true also then that it is best to use the gadolinium, especially if you think that you have a patient or the patient thinks that he or she might be worsening, and you do want to give.
Again, I always prefer to give contrast because a
Right.
contrast enhancing lesion teaches me a tremendous amount. So left to my druthers, I will still get contrast. There are
Right.
many MS neurologists that have stopped because the extra amount that you get, in their opinion, isn't worth the squeeze. And so you're hearing my biased opinion, which doesn't make me right. It just makes me really opinionated.
Yep. And I don't mean to ask the same question 90 different ways, but there are a lot of people out there that need to hear it 90 different ways, because one of those 90 is their way of wanting to know more, right? Okay. Next, person writes, with central vein sign, do we need contrast or just regular T2 lesions?
That's a great question. You don't need contrast, and it's not a T2 sequence. All right, so when you get in the scanner, you know how it makes different noises? Like for 5 minutes, it'll go bing, 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 and then it'll go bang, bang, bang. Those different sounds are different kinds of pictures. T2 is one kind of picture. So the kind of picture that we're talking about here is called SWI, or susceptibility weighted imaging. And that's the picture where we can see a central vein sign, or we can see the paramagnetic rims, the pearls. And so we want to make sure that the MRI includes a SWI sequence so that we can look for central vein sign and pearls, but it doesn't require contrast.
Okay, thank you. Person writes that they never had a spinal tap, yet they were diagnosed with MS. So how is it that they learn more about their O-bands without the spinal tap?
So you don't need a spinal tap to confirm a diagnosis, but spinal fluid positivity contributes to the diagnosis. So the majority of my patients have not needed a spinal tap to be diagnosed. There are some patients where the spinal tap can help confirm a diagnosis. So if you have MS and it's been confirmed through MRIs, let's say, you don't need to go back and have a spinal tap. It's not necessary. 90% of people with MS have the changes on the spinal fluid that I mentioned. So 10% don't. So, if you already have the diagnosis, there's no need to put yourself through that.
Okay, thank you. And I'll stay on the O-bands for a while. Can a person writes, can steroids affect oligoclonal bands?
Steroids cannot affect oligoclonal bands, but they can affect other things like antibodies for MOG or antibodies for NMO.
Okay, next, going back to the central vein sign, does it need to be be done in a certain Tesla machine or
So no, you could do it on a 3T or a 1.5, but I'll tell you that it's better on a 3T. So the higher field magnet, the higher the Tesla strength, the better the image quality. And so I think SWI on a 3T is superior.
Okay, great. Can you tell us about the ecometrics algorithms and why this is being pushed at many centers now? And are there any other similar systems that are using the same algorithms?
Yeah. So one of the things that we know to be true with MS is that someone can have an attack, which is bad, or someone can have progression of neurological disability, which is bad, or someone can have a new lesion on the MRI, which is bad. But there's a fourth thing that we have to pay attention to, which is how the brain shrinks over time. All brains shrink as we age, in the same way that we get shorter as we age and our skin gets thinner as we age. But brains of people with MS, particularly untreated, can shrink much faster. And that correlates with bad things like cognitive impairment and progression of disability. So fortunately, many of the MS medicines, not all, but many of them slow that down, and they can help the brain age at a normal rate and shrink at a normal rate, which is very, very good. And there are some MRI softwares that can measure that. So Oncometric is a company, a very good company that makes a product. And there's another one called NeuroQuant, which is a different company that makes a product. And both of these products are FDA approved, and certain imaging centers use them. So for example, the imaging center that I use happens to use NeuroQuant. Other ones would use Oncometric. Both are outstanding. And what they do is they basically leverage AI, artificial intelligence. They look at the picture and they pull out the volume of the brain and of the parts of the brain. So they do all the math to calculate the volume of each piece of brain, and they compare it to standard averages. And I use this in my clinical practice, where I can look at someone's brain volume, the size of their brain or the parts of their brain, and I can compare it to someone who is the same biologic sex and the same age. And so it allows me to look at if there's an accelerated rate of brain volume loss. And I find that to be very, very useful in clinical practice. Now, it's not included in every MRI. I think it should be for MS. It's not part of the diagnostic criteria, but it's one of the factors that I look at when I'm trying to see response to therapy, for example. That was a great question.
Good, thank you. All right, next one writes, if you believe that MS is one disease with different presentations, then how does that change how PPMS patients like this person are treated?
So right now, we have one proven medicine to treat primary progressive MS, where we've done a trial and proven it, and that's a medicine called ocrelizumab. But if you talk to any MS neurologist, we'll almost all agree that any B-cell medicine should be able to treat PPMS. And for that matter, other medicines which function and impact B cells should be able to treat PPMS. So we've done these clinical trials where we make up these arbitrary rules, and then something only gets approved for relapsing MS. And this is a reason. This exactly explains why I don't want to fracture the diagnosis. Because right now, if something's approved for relapsing MS, insurance won't allow you to use it for PPMS. Some of them have never been tested in PPMS, and they might work, but we don't know. And so if you recognize that it's probably the same disease, I think it opens the door for us to experiment and find more therapies to work in progression. That's my opinion.
Okay, thank you. All right, next, I don't know where you were speaking about at the time, but a person wrote, what was number 5? You said number 1, clinical history.
Yeah. So 5 things to diagnose someone with MS, if I use patient-friendly language: your story, your exam, your imaging, your MRI, your spinal fluid, prove it's nothing else. So number 5 is prove it's nothing else.
Okay, there you go on that. All right, next one. Does barometric pressure impact multiple sclerosis symptoms?
Not that I'm aware of. I've not seen data to prove that. Anecdotally, I have several patients that tell me they can tell when the barometric pressure is changing because their symptoms change. So I don't know the answer, but I'm not aware of data that has been proven that.
Funny, I could tell when the pressure's changing because I know it's about to rain.
It's like a spidey sense.
Yes. All right, next one. With the new criteria, is there a danger of possibly overdiagnosing MS?
With the new criteria, there's less of a risk with overdiagnosing MS by a long shot. That's one of the new values to the new criteria, is it will do a better job of parsing out what isn't MS.
Great, thank you. Next, Totally geeking out with Dr. B over the new MS criteria is my favorite. Okay.
Thanks.
Next.
Me too.
Next, what do you look for regarding IgG levels?
So IgG is a doctor word for antibodies, and specifically memory antibodies. And the question is missing context. So, for example, what I think I'm going to guess they're talking about is how do you use IgG to monitor the safety of a B cell depleter? So I'm just going to assume that's what they actually meant to say. When I'm giving someone a B cell medicine, Kesimpta, Briumvi, Ocrevus, Rituxan, I'm suppressing their B cells on purpose so that I can stop the MS from attacking the brain. But suppressing the B cells risks creating a risk for infection. So I monitor 2 laboratories to help guide me about whether there's an increased risk for infection. One of the values I look at is the lymphocyte count, which is part of the white blood cells, and the other is the IgG. And I like the IgG level to be above 600 while I'm treating someone, because I feel like if you have at least a 600, then you have enough antibodies to fight off bad guys. And if it goes below 600, it doesn't mean gloom and doom. It just means that we're a slight increased risk of infection. And it might drive us at my center, at the Boster Center for MS, to delay your therapy to allow you more time to build back those antibodies.
Great, thank you. So, interesting question. Not that they're not all interesting, but here's another interesting question. If a person is on Tysabri, but they all of a sudden turn positive, and they're low positive, but their doctor doesn't want them to stay on Tysabri, so the doctor takes them off Tysabri and puts them onto a form of a B cell depleter, I'll say. I'm not going to say by name. But then the B cell depleter actually isn't working for them, and they find that the person is getting worse again. Is it possible then to go back onto the Tysabri?
Yes, it's possible. The risk increases potentially, but it is possible. So let's talk through this. Tysabri is one of the most effective drugs to treat MS. It's right up there with the Ocrevus, and it's a real good drug. And the biggest risk with Tysabri is if you have been exposed to the JC virus, so we test your blood and your JC virus antibody positive, and you take Tysabri, there's a really small risk of a very scary infection of your brain called PML. And PML is very, very serious. It can kill you. It can make you disabled. It's nothing to joke about. And so when someone takes Tysabri, they have to weigh the benefit to the MS against the risk of this infection. Now, a lot of neurologists are scared tiny little boys and girls that are terrified of risk, so much so that they don't want any risk. And so if someone with MS is on Tysabri and they become positive, the neurologist has a poopy accident in their pants and they take them off the Tysabri for fear that they would have this infection. And by the way I'm talking, you can understand or glean that I don't agree with that, because I think that you're taking them off something that's highly effective for a very, 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 very small risk. And I don't think that's the neurologist's call, my opinion. I don't think it's the right of the neurologist to paternalistically tell you that you can't take something or you can. I think it's the obligation of the neurologist to educate about the risk and then to allow the human to make an informed decision. I'll give you an example. I have a patient who has been on Tysabri for 12 years. She's almost 80. She's antibody positive, low positive, and has been for years. And she happens to be a physician, and she's very smart. And she has looked at all the data and said, Aaron, I don't want to come off. I accept that risk. So I think she's capable of making that decision. And I think most people are, if you just explain it to them. Okay, so that's the first piece. In this case, they took them off the drug and they put them on a B cell depleter. And the question is, can you go back to the Tysabri? Now, there are some neurologists that would say you can't because the risk of the PML might be higher. Well, although that's not true, you can, it's just the risk is higher. Here's the thing. Everything in life is a risk benefit, and the risk benefit's constantly changing. And if the risk benefit is changing, you have to reevaluate. So if you're not able to control the MS and you must control the MS, you might need to revisit a therapy that worked at one point in time. So that's a very long-winded answer. I apologize. The short answer is yes, you can do it, but the risk might be slightly higher.
Thank you. A person writes, I saw a report that the cause of MS has been linked to a bacteria. Is this true?
No.
It's a quick answer. All right, next one. Does MS cause small fiber neuropathy?
No. So let's talk about that. So if you have damage to your nervous system, it can cause pain. MS can cause damage to the nervous system, which can cause pain. And the damage comes from, most of the time, from the spinal cord or the brain. And that can cause brain-related or spinal cord-related pain. For example, it can make your feet burn. There's nerves that go from your spinal cord into your limbs, like I'm showing you my arm, but it could also be my leg. If those nerves become damaged, you can also have a burning leg, and that's actually from a different part of the nervous system. So in neurology, we don't say neuropathy to mean pain. That means pain from a peripheral nerve. Right? And so MS doesn't cause a peripheral neuropathy. It can cause neuropathic pain, but it's coming from the spinal cord. Now, here's the kicker. The medicines to treat both, same medicines.
Okay, thank you. All right, person writes, and this is going back to slightly something that we were talking about, definitely something we were talking about before. I thought I heard a kitty go in there, and I'm saying, I know I don't have a cat. Where am I hearing this from? All right, my neurologist said a new drug for MS would be approved in a month, October, probably by the FDA for secondary progressive MS, but it is very hard on the liver, and why would we have to watch the liver with a lot of follow-up, and that we would have to watch the liver with a lot of follow-up tests? Your thoughts on this, please.
So they're talking about the medicine that we mentioned earlier, tolobrutinib. They're talking about the Hercules trial and possibly being approved for secondary progressive MS. Now, if it's approved for secondary progressive MS, and we'll know in December because the FDA kicked it 3 months, they're going to have some very stringent rules surrounding liver monitoring. BTK inhibitors are not new. They're new in MS, but they're not new. We've been using them in cancer for a long time. And one of the things that we know to be true with BTK inhibitors, in some people, they can damage your liver. They can cause your liver enzymes to skyrocket. And the monitoring is critically important to keep someone safe, right? So I ran these clinical trials, and we experienced this where if someone has an elevation on their liver enzymes and you hold the medicine, then it comes back down, they're okay. So monitoring is very, very important to keep someone safe. And because we know that people are at risk, we're going to do that. And probably we're going to end up checking liver enzymes weekly for months, potentially as often as weekly for a couple months to make sure that they're safe. Now, once you get past 3 months, the liver enzymes don't tend to spike like that. So you're not going to have to do that for all of time, but there is a high likelihood that we're going to have some very, very intense monitoring early on, and it's 100% to help keep people safe.
Okay, thank you. All right, everybody, I know that I asked you all for questions, but now I'm going to ask you not to type any more questions because we have way too many at this point in time, all right? So I'm going to start flying through these a little bit quicker and trying not to add my own commentary. All right, what are your thoughts on stem cell cures?
Stem cell transplantation is not a cure. Period. It's not a cure.
Okay. Can you explain why? Because I know that they're dying to ask why.
Sure. So
add my commentary.
Stem cell transplantation does not cure the disease. In very aggressive MS, it can slow it down when other things can't, which is awesome, but it doesn't cure the condition. And that's a fact. If you look at people that have a stem cell transplant, some of them go on to have active disease, and I've seen it in my clinic many, many times. It is an outstanding aggressive intervention for really aggressive MS, but it's not a cure.
Okay, thank you. Next, is there any symptom differences or for PPMS and RMS, both only seen in one type or never seen?
No.
Okay, next. Could you address the use of metformin and clemastine?
Clemastine,
Yeah,
yeah.
that for MS.
So clemastine is a medicine related to Benadryl, all right? So it's an antihistamine. And metformin is an oral medicine for diabetes. Neither are approved to use in MS. Both are currently being studied because they may help with remyelination in MS. And those studies are still ongoing, and so we don't yet have updates.
Okay, thank you. Next, how do you figure out if someone is an Ampera responder?
Ampera is a pill taken twice a day. And in about 30% of people, it's approved for MS, 30% of people that take it, it buttresses against heat sensitivity. So when they exercise and heat their core body temperature up, they don't short circuit. Or when they go out in the summer sun and they heat their core body up, they don't short circuit. And what happens in those responders is when they go and get overheated, they don't lose neurological functions the way they would if they weren't on the pill. But that's about a third of people respond to it. And Stuart, what was the beginning of the question? I'm very sorry. Can you repeat it, or is it gone?
I'll let you know in a minute. It's bad enough I left out part of the first question that I asked you before that. I don't remember.
So
Moving around.
Formidopyridine is a medicine that helps with heat sensitivity. Go ahead if you remember the rest of the question. So don't butcher
Yeah, they were just asking if it was if you know of it being a responder.
Okay, that's right. So how do you know if if it works or it doesn't work? I have come up with a way which always answers the question. You give it to the human for 2 months, and at the end of 2 months, they will give you a solid, accurate answer because they'll experience one of two things. Either they will have a Lazarus effect where they say, oh my golly, I can't believe how much better I am in the heat. I refuse to take my Ampera away. Try to take it away from me, I'll fight you for it, right? Because it really provides a value. Or they'll say, so what do you mean, So, I don't know if it worked or not. And if they're not sure if it worked, then it didn't work. And then we stop the medicine. But you got to give it 2 months. I used to give it 1 month, and that's not long enough. Sorry, I forgot the question halfway through.
Okay, now let me go back to the other question I did before that. They wanted to know if the metformin or the clemastine is on trial in the United States.
Yes, I believe so.
And if you know so, can you tell them where they can look?
Clinicaltrials.gov is the government website, clinicaltrials.gov, and type in multiple sclerosis clemastine or multiple sclerosis metformin, and it'll show you exactly where those trials are located.
Okay, thank you. This is a long question. All right, let's take one long question after another. Dr. Boster's first bout with optic neuritis, 1985, second in 1993. MRI showed white spots in the brain. Spine was on Avonex pen shot for 12 years, was on Avonex shot for years. Prior to Avonex pen shot, my neurologist took me off Avonex pen shot about 2 years. Said MS patients get older, attacks lesser. I feel like my balance, which got unstable in 2013, has in the last year or so gotten worse. It's not awful, but it's definitely an issue. Also, in the last, after DEXA scan showed I have osteoporosis, show place of osteoporosis, and 2.9 have other My primary care physician tells me to definitely not fall, so I've been using a 4-wheel walker. Do you think I should be an MS medication be on an MS medication for balance?
Yes.
Long question for that.
So the answer is really simple. Yes. 1/3 of people over the age of 55 who stop their medicine progress in disability. You're progressing in disability because they took you off your medicine. So go back on a medicine for the love of all that is holy. Yes, yes, yes.
Great. Next long one. This sensitive subject, but I have a question about vaccines and can't seem to get a straight answer from my providers. I'm starting Ocrevus this Friday. I just want to know what and when I should get flu, COVID, pneumonia, and shingles vaccines. My doc says I'm immune to Hep B and that I should wait 3 months after my race T COVID infection positive on September 9th. I know it's too late to get them, but pre-infusion, but wanting to know the timing for after I start.
Okay, all right. So vaccines have saved more lives than any other medical intervention in the history of the planet Earth. Vaccines are a godsend, right? And vaccines help us from dying. So this year, Aaron, just got my varicella vaccine because I'm now 50, right? And it has been shown to decrease risk of Alzheimer's. So I would like to decrease my risk of Alzheimer's. So I got the vaccine for varicella. I got the flu vaccine because I'm a doctor and I'm around a lot of people who are ill and I can't afford to be ill because I need to be able to help people. So I got the flu vaccine, right? I got the pneumonia vaccine for the exact same reason, right? Because I'm 50 and I'm at risk for that. And I got the COVID vaccine. So I am a big proponent and I think it's really smart. So what do you do if you have MS? The same thing, right? I recommend that my patients get all those vaccines. And if you're on a B-cell depleter, it might dampen the vaccine's response, but it'll still work. So let's make up numbers. Let's pretend that when I take a vaccine, like for COVID, it's 80% effective. I just made up that number. So if you're on a B-cell depleter, maybe for you, it would be 60% effective. So the numbers are made up, but my point is it would be less effective, but it would still help. So I would still get it. The ideal would be to do it, in my opinion, a month before your next infusion, right? Why? Because if your immune system is going to start to reconstitute, that's about as much as it's going to reconstitute. And the label says that you need to have at least 2 weeks between the vaccine and the infusion. I feel better if it's a month. So I like my patients to get updated vaccines about a month before their infusions.
Okay, thank you. And I am the opposite. I hate to say, but I don't do the vaccines. I have done vaccines, but then I did COVID 4 times and I got COVID 5 times. So, you know,
what the data? So what I tell people is that you're an adult and you get to make your decision for you. My job is to educate you. And then once I educate you, then you can make an adult decision. And I'm allowed to say that I agree or disagree, but you're allowed to pick because you're in charge of you. What we found real quick during COVID, for example, was people with MS that were vaccinated died less when they got COVID, and they were hospitalized less when they got COVID compared to people with MS that didn't get vaccinated.
Okay. I want to break away from the MS stuff for a minute. You mentioned the varicella vaccine. You said that it reduces your chance for Alzheimer's. I'm asking this question, everybody, because my dad has Alzheimer's, and right now he's in the hospital and sliding down really quick. And I just need to ask if this is something that would benefit me at this point in time, or is it already in my genes?
So I'm not familiar enough with the data, Stu, to comment. I know that it's recommended at 50 and that it's been shown to decrease, but I can't answer that level. I'm sorry. I'll find out for you though.
No problem. And it doesn't help that I'm not 50. I got you by 17 years, right? Okay. All right. Next, we have, would a regular ophthalmologist be able to run these tests, or would it be a specialized ophthalmologist?
So the 2 tests that you need, one is called ocular coherence tomography, right? OCT. And OCT. And that's a machine that I think pretty much any ophthalmologist will have one. A neuro-ophthalmologist will definitely have one, but any ophthalmologist should have one. Even an optometrician who makes glasses will have one. The other test is called VEP, or visual evoked potentials. And that most ophthalmologists should also have. And so if you're being sent for a workup, the neurologist should have already made sure that the ophthalmologist is sending you to can do all those tests. You shouldn't have to check.
Right. But I will add to that and say that those that live in rural areas may not have that availability at their ophthalmologist's office, simply because the costs are a lot greater for them to survive.
No, one comment that I think is very relevant. You don't have to have those tests to diagnose MS. They can just help contribute. So you can diagnose MS the way that we did yesterday, just with the MRI brain and spinal cord. It's just that you may get to a diagnosis faster with those other elements.
Okay, thank you for that. Next one. Have you used the Octave blood test, MSDA test, and if so, how useful is it?
Yep. So let's talk about this. Yes, I have, and I find it very useful. So there's a company called Octave, and they made a laboratory which has been approved by the FDA, and it measures inflammatory MS activity. So it is predictive of disease activity, meaning a new attack or new spots on the MRI. It's a blood test. And right now, unfortunately, it's not yet approved by most insurance companies. And so I think it will be soon, but presently it's not. And you can't just go like to a Quest or a LabCorp and get it. It can only be obtained from MS centers like the Boster Center. And you send it to the company, and they produce this result, which I'll explain in a second. Now, right now, patients have to pay out of pocket for it on a sliding scale, and patients can pay upwards of like $300 for this test, which for a lot of patients is simply not affordable. I do think in the future, when it's going to be covered by insurance, then it will be readily available. The test gives you a number, and the way the number is generated is interesting. There's 18 different labs that are being looked at, and all the results of the labs culminate into a single number called the multiple sclerosis disease activity, or MSDA number. And a high number is very bad, and a low number is very good. And so it puts it into a low, medium, or high number. If you have a low number, that would suggest a very low probability to go on to have an attack or a new spot. And if you have a high number, there's a high probability. So it's a very useful test. Now, presently, I get it in patients when we're trying to collect as much information as possible to make decisions. And some of my patients who have adequate resources choose to obtain it to help in our monitoring. If the test was approved by insurance, I would get it in almost every one of my patients 4 times a year, and I would follow it quarterly. That's how important I think it will become.
How effective is what they're hoping to find, though, of the use of the getting the test all the time? I mean, I know the plan was that they can basically, I don't want to use the word predict, but they'll be able to foresee what or how bad a person might be getting. And how far along is it now that they're able to actually find that and then know how better to treat the patient?
So there's been some studies, early small studies, looking at using this tool to make decisions. I can tell you that I have used it to help make decisions in my clinic, not by itself, but in conjunction with other things. And so I think there's a value there, but I don't think it's like the end all be all. I do think that it's another piece of information which can help inform decisions. And you could imagine obtaining that in place of an MRI, not all the time, but sometimes. And so that would be really powerful.
Okay, thank you. There's just so many questions. I'm trying to find what are some of the different ones that haven't been out there yet. Is with the PML, and is it possible for a person using Ocrevus over the age of 65 to get PML from Ocrevus?
So the biggest risk factor for PML is well, I guess is age. So as you get older, you have a slight increased risk of PML. So could you get PML at any age? You could. As you get older, is it increased? Maybe a little. It doesn't look like Ocrevus, Rituxan, Briumvi, they increase the risk significantly in the MS population of PML. We have a bunch of people, like 170,000 some people on Ocrevus, and the number of cases of PML not attributable to another drug before Ocrevus would suggest that it's the same risk as the general population. I, for one, when I'm worried about the possibility of PML, I put them on a medicine like a B-cell depleter to avoid that risk. So is it possible? It's possible, but I think the risk is still quite low.
Okay, thank you. Next, if able to get onto a BTK in the future, will they be able to use a second therapy with that?
So that's what I would like to see happen, and I doubt that it'll be allowed because of the almighty dollar and the cost for insurance. And so I hope that in the future we can stack medicines like that, because I think that's brilliant, because you're using different mechanisms to try to accomplish a complex goal. I just think that insurance would be reluctant to do that. Also, if we're ever going to pull that off, we'll probably have to do a clinical trial to prove it. And right now, all of the BTK molecules are being tested in monotherapy, with the exception of a trial that we're getting ready to start with a manufacturer, where they're going to look at adding it on to another MS medication, an oral medication. So that's a phase 2 trial that we're getting ready to start that I'm very excited about.
Great. All right. If Mavenclad is used and it goes into year 2, can year 2 dosage be given prior to 12 months from the last?
No.
And reason for that?
It's dangerous. It's dangerous because you're not, and it's also going to risk making the drug not work as well. Mavenclad needs to drop the cells down and to let them come back up. You have to let them come back up, and then you do it a second time, right? But you don't want to rush that or it won't work. It's a pulsed microinduction, so you have to have the pulses.
Okay, thank you. I'm reading this question. It obviously has nothing to do with me. I've had a few bad months of vaginal infections, herpes virus 1, keratitis or something, and then COVID. I'm on Ocrevus. Is it time to change?
Maybe. So I think that's worthwhile talking to your neurologist about. I also think that I would be looking at the lymphocyte count, the ALC, to make sure that that's not below 600. I would be looking at the IgG levels to make sure they're not below 600. But you might need to, or you might need to delay it to allow your immune system to reconstitute. But again, that's something that I would absolutely discuss with your neurologist.
Great. Next one writes, I'm on a DMT specifically because of low lymphocytes. Is there a DMT that would be safe for me to, I'm not on a DMT specifically because of low lymphocytes. Is there a DMT that would be safe to be taken?
Yes. So Copaxone would be safe. It's possible that Vumerity and Tecfidera would be safe. There's about a 20% chance that it would make the counts go lower. So that's a possibility. Off-label, I would use IVIG in that patient. Now, it's off-label and it's very expensive and challenging to get through insurance, but if you get through the insurance, then that would keep them safe. It would actually decrease the risk for infection, and it would also treat the MS.
Thank you. Next, in my sampling of MS patients, it appears that most people with MS diagnosis have advanced degrees. Do MS people usually have a higher than normal IQ, or are we just overachievers?
Neither. You have a biased sample. So I would not submit that people with MS are more or less intelligent than the general population. They're not taller or shorter than the general population. They are obviously more attractive than the general population, but that's the only outward appearance that's different.
I just want to add to that simply by saying I think there's more information out there about MS than most every other disease that's there as far as neuroimmune diseases. Okay, that's my input. Okay, I know I'm not supposed to do that. All right, I'm pretty nervous about what's that?
I said, you're all right.
Yeah, I got it. Person writes, I'm pretty nervous about being so immune compromised as I'm also starting IL-17 inhibitor for psoriasis. What can you say about that?
I can say that that's very complex and that we need a careful coordination between your dermatologist managing the psoriasis and your neurologist managing the MS. There are monoclonal antibodies that play nicely together in the sandbox. And so you have to have a sit-down discussion to sort all those details out. It can be done.
Right. All right, next one. Do you know of the new criteria help us get closer to understanding smoldering MS?
I don't think the criteria are set up to help us get a better understanding of smoldering MS. I think it gets us a faster, more accurate diagnosis of any kind of MS, but I don't know that it takes us closer or farther away to that. I will share that the pearls, the paragnathic rims, are very, very commonly associated with smoldering MS and progression.
Good, thank you. Next, why would a neuro not give steroids for a flare if the patient has very bad depression?
Steroids can cause worsening depression, and in some patients can cause psychosis, and in some patients can cause suicidal ideation. And so if a patient is really depressed, you would risk potentially making them worse with steroids. So in that instance, the neurologist might choose to admit the patient so that they can be under direct observation in the hospital. God forbid they're not okay, or they may want to hold the steroids for that reason. Although that's conjecture. I'm assuming that's why.
Thank you. Next person writes now, so is steroids also bad for lung activity?
No, I don't think that you can say steroids are bad for lung activity. So we're getting close to the end, guys.
Yeah, we are getting very close to the end. Is the term relapsing remitting MS no longer used?
It's unfortunately still being used. I prefer calling it relapsing MS because I think relapsing remitting is a bit confusing and disingenuous, but presently it's still used, yes.
I'm on Imbruvica for CLL and was on Tecfidera, and my neuro said I no longer need to take Tecfidera.
Not enough information to be able to comment on that.
Gotcha. School. So yeah, we have this school website. Somebody wanted me to mention this really quick, and I'm going to end the night with this. MS Views and News has a community chat available from our website. Okay, Kevin, thank you very much. He's been hounding me for weeks to make sure I say this, and I asked him to remind me. So the answer is yes. We have a community chat. You can go to our website. You can get on there. You can get involved. Be with over 400 other people that are now using the site. And we just started this in July, and we do expect it to continue to build. So just go to schools, SKOOL.com /MS Views and News. Thank you. And if you need any more questions about that, just write to Kevin. All right. Thank you. All right, Dr. Boster, again, thank you very, very much for an awesome evening. You answered a lot. You gave a lot of information. Everybody that's online with us each time, I do want to thank you as well, because we couldn't do these programs without having you there. All right, and if there was a question not asked and answered by me and answered by Dr. Boster, I'm sorry, but we are out of time. Thank you, everybody.
Have a great night.
Backward. Bring it again in next 2 months. Thank you. Have a great night.